Okay, assalamu alaikum everyone. This is Fawad Chaudhary. So we're going to start tonight's webinar, and the structure would be the same. Dr. Moteen, she will introduce herself, and then she will go over with the presentation, and then we will try to answer as many questions as possible. I got some questions on the WhatsApp as well, so as I mentioned, we'll try to get to as much as possible. We have some new people on the panel list as well. We will introduce them quickly after Dr. Moteen's presentation as well. So just in the interest of time, I'll go ahead and ask Dr. Moteen to introduce herself and start her presentation. Dr. Moteen, please, you're unmuted, please go ahead.
Assalamualaikum. The purpose of this talk today is to assist in the discussion of COVID-19 related issues. And what we need to do is emphasize on value and effect of social distancing and of universal precaution. I want to thank the APPNA MERIT organization for bringing up this topic up to part international level and allowing for a platform for keeping us up to date on prevention strategies being practiced and the challenges being faced both in Pakistan as well as in the United States. As Dr. Shahid just mentioned, my name is Maryam Moteen. I'm a staff cardiologist at Loma Linda VA Medical Center. I am a graduate of Dow Medical College 1980, and I'm the president-elect of APCNA, which is an association of Pakistani cardiologists of North America. Our mission is to foster scientific development and education in the field of cardiology in North America and Pakistan. I do hold a faculty position as full professor of medicine at Loma Linda University, as well as in a UCR, which is University of California, Riverside School of Medicine. And I work full-time at the VA, and I have been with the VA for the last 30 years. To begin with, what I did was bring in 2 CT scans on the top. These are available online for everybody to view, which shows the appearance of COVID-19 infection, most particularly in the lungs of people on the Diamond Princess cruise liner that brought more attention to the COVID-19 infection in USA. This was also discussed by Dr. Kaleem a couple of days ago at this particular meeting. COVID-19, as we all know, stands for coronavirus disease, which started in 2019. In order to prevent stigmatization, the country of origin is not included in the name, as you can see here. It became pandemic when it crossed continental boundaries and now has affected well over 165 countries. The full magnitude of public health will not be determined for quite some time to come. In addition, there's a great need for rapid testing for COVID-19 infection and immunity. Quite a few countries have set up websites for information of COVID-19 infection. A couple of examples that I've posted here. The top one is an example from New Zealand, and the lower one is from CDC. We know that the virus is still unfolding its ravages, and we still may have a long way to go, but we need to band together and share information as it becomes known to everybody. These websites allow specific information as needed without overwhelming the readers. These websites are updated very frequently, and I believe such an approach is much better than raising stress with COVID. For example, we have uncertainty, what will happen? Instead of questioning, we need to look at the landscape and use it as a challenge and find ways to work with it. We worry about the prediction models. The biostatisticians, epidemiologists, and public health organization people are working hard to make it more plausible and applicable as more and more information about the new disease is coming. We worry about the protection, not just about ourselves, but also those around us, with the intent to prevent and treat as we deem most appropriate. We are all afraid about it infecting ourselves and our family and everyone around us. This is because the statistics are very sobering. And as you could see from China, anyone who is greater than 60 years of age, mortality was reported to be greater than 80%. In US, more than half of the hospitalization and ICU admissions are of those greater than 65 years of age, and 80% of those people that die are reported to be greater than 65 years of age. This tells us that this virus does not know the difference between the type of the country, whether it's an advanced country with excellent resources or a country of densely populated country with limited resources, and it does not differentiate between either of the two. Adults with multiple comorbidities, polypharmacy, frailty are the highest risk for morbidity and mortality with COVID-19. 40% of the total population in USA is at high risk for serious illnesses of COVID-19 because of age greater than 60 years or underlying comorbidities. The number of infection and deaths globally are staggering, as shown here, with over 79,000 deaths about more than almost like 10 days ago. And now it's reported 120, and this morning it was 150 deaths were reported. That means that the virus is taking its toll and is rampant. In USA, it had 30,000 deaths a week ago, and now this morning it was reported to be greater than 40,000. The case distribution shown here shows that the US has a bigger pie of case workload, and we have not yet been able to contain the virus, and the peak may be yet to come. Some models are predicting a peak. I'm surprised to know it's late May to June, early June 2020. The thought is mind-shattering. While New York has been the epicenter in USA, California appears to have less number of cases. A snapshot shown here shows that the California, in spite of having a large, densely populated area, seem to have less number of cases. 789 cases were reported 10 days ago, with 25,000 deaths in US confirmed. In San Bernardino County, where I am, the numbers are less, and as you can see, it took a little while for the numbers to rise in here because it is a less populated area, and it is unclear if the curve over here has flattened. Two important points that we are noticing. In contrast to what is being reported, we are seeing younger people with COVID-19 infection, as you can see at the bar at the bottom, with the age group between 40 to 64 being the highest infection rate, with equal distribution among men and women. This snapshot was taken a week ago, and this shows the counties or the towns around Loma Linda University, and it shows that the counties are being looked at are mostly of ethnic groups that are around Loma Linda, not necessarily in Loma Linda, which is in the middle, or in Redlands, which is in the middle. And these are the mixed ethnic backgrounds, and they have increased population density. This is a snapshot from LA County, which is about 50 miles away from where I am, where the population density is higher and the rate of infection and death is increasing at an alarming rate, as you can see. Social distancing is now being enforced. California as a whole is done much, much better, as seen in this chart, with per capita infection much lower than New York and New Jersey, as you can see here, with New York having 963 cases per 100,000 K, whereas California having 59 cases per 100,000 K. And this is secondary to early lockdown and social distancing that was practiced as soon as the virus issues were raised. In addition, you can see the number of cases. California has relatively less number of cases, 1.7 per 100,000 K, as you can see here, in contrast to New York, which has 47.8 cases. California overall has already flattened the curve, as we can see here, but it is untrue if it's really going to hold true, because the social distancing has now become an issue and it may spike again. Deaths are still on the increasing side overall because these patients were already admitted to the hospital, and we are still learning how to take care of these patients. San Bernardino County, there is a decrease in the increment of number of cases and the multiplication of cases, and we hope it continues to stay as such, and in fact, try and go towards a downward trend. Measures to decrease the thing, and it's mostly dependent on concentration and effective triage that is being done here. No essential services are allowed in California. That includes any kind of malls. Restaurants are closed. You can only have takeouts, no salons, nothing is allowed on the outside. Essential services have established triage areas at main entrances outside of the building. Hospital screens all individuals, irrespective of who they are, with everyone practicing social distancing. That includes incoming patients and employees as well. No visitors are allowed, except an occasional exception being an ICU with special permission. They're separated on base of symptoms and presentation. non-respiratory symptoms, and those that pass the screen are given a mask and taken inside for further follow-up. If a patient present with a COVID-like symptoms, they're given a mask and then fast-tracked by an ED nurse screener and straight taken to an isolated area for care. We have specific inpatient units that have been identified for suspected and confirmed COVID-19 patients. VA had initially a concern for a higher rate of infection, but this is not as high as anticipated as of yet. This is one of the areas where the COVID suspected cases are taken, or somebody that has respiratory symptoms that are concerning. And we have 4 of these lined out outside in our emergency room. That means anybody that is suspected is positive on screen, they're not allowed to enter the building. We have special entry areas. Employees are expected to enter through the employee entrance only. Patient and vendors delivery pickup come through the manned areas. And the questionnaire that is given is either verbal or by using telescreening in some parts of the VA, so that the person that's doing the screening does not really have to come face to face with the person that is being presented for them to screen. Those that are screened out negative, they get a temperature check, and after they are negative with the temperature check, they get an armband, and only then they are allowed to come to the emergency room. We follow the CDC guidance for face mask and PPE, and this is reflected in here. We follow the CDC guideline to the dot. Face cover, when we are out in the public, it's a cloth mask. It is mandated in California. No one is allowed to be out on the street without a face mask. CD guidance for PPE for healthcare worker taking care of COVID negative patient is on universal precaution, whereas those that have a positive patient, they have to have a full PPE. Appropriate personal precautions are given for everyone. At first, it was initially thought that we would not require a mask at a distance of 6 feet, but now everybody has a mask on, and surgical mask is required only when the person is suspected of COVID positive, some kind of symptoms of positive COVID. Upon entry into the VA, all of us are screened when we join the VA, and we all get are fitted for N95 mask. And at the time of any kind of pandemic, each one of us is given an N95 mask to be kept in the office or in the purses, whichever way you like, to be used as and when it's needed. COVID testing at our hospital is present. With the rapid testing is only in limited amount, but we have unlimited 24-hour testing. And it is done according to what the CDC guidance is, as it is shown here in the chart, is reflected on the side. Outpatient cases, we have seen about 13 of them in the last month, and 6 staff members have been positive, and they have been all quarantined and not allowed to come to the hospital. They're called every single day to find out about the temperature and about the symptoms and make sure that they're following the quarantine period as recommended. Hospital is trying to keep itself ready for more cases with appropriate surge plans. We also have a new ICU already built up with 16 beds. We do not know when the peak is going to be expected. The reason we are worried about these patients is most of our patients have cardiac issue, and we have a very wide catchment area, about 150-mile radius that includes Arizona as well as Nevada. We expect some cardiac complications that has been reported in the literature. That includes acute cardiac injury, shock and arrhythmias, and we're on the lookout for that. Questions about interstitial mononuclear inflammatory cells have been raised a few times, and we have had a couple of cases in the past couple of months that have developed myocarditis with a reduced ejection fraction heart failure. In the literature, one case of Takasubo syndrome, that means no obstructive coronary artery disease, but ballooning of the LV apex has been reported. And there's one case of transient complete heart block that has been reported in the literature. ICU admissions generally tend to increase 2 to 3-fold when there's comorbid condition, and our patients have it, which is hypertension, diabetes, coronary artery disease, COPD, asthma, and as well as obesity, to name a few. We're on the lookout for the cardiac injury. Most patients that we have heard about and that are coming into the hospital have predominantly respiratory symptoms, some with severe cardiovascular sequelae. cause of death is usually combined cardiovascular and pulmonary problems. A lot of questions have been raised in this seminar and the series of talk about the ACE2 membrane-linked aminopeptidase and receptor through which the virus can potentially attach to cause respiratory structure and mediate some tissue injury. Yet there are no supporting data to say if it really happens. And all the society, Heart Failure Society, ACC, and American Heart Association have not come up with any guidance. They say continue with the medication as they're being given. I run the heart failure clinic with 3 NPs, 1 social worker, 1 RN, 1 case manager, 1 pharmacist, and 1 LVN. So we get a lot of calls about it, and we are not modifying anybody's ACE inhibitors or ARBs at this time. Troponin elevation has been reported in the literature, 17 cases, and it's higher the troponin, higher the chances of mortality. We had 1 case in which the troponin was elevated out of 16 that were admitted in the past couple of months. Abnormal coagulation parameters have been discussed quite a bit in the previous seminars online with the APPNA MERIT. And we have seen elevated levels of fibrin degradation products and D-dimers. Anticoagulation role has varied. In New York, it has been given, whereas at our institution, no specific guidelines has been set, and it has been left up to the individual provider to decide if they want to give any anticoagulation to the patient or not. Usually with COVID-19, we're expecting more heart failures and arrhythmias because there has been early signals of excess heart failure, myocardial injury, and myocarditis and arrhythmias. In China, heart failure was reported in 23% of the patient, was more frequent among non-survivors, and it is unclear if cardiomyopathy is from underlying inflammatory state, hypoxia or hemodynamic impairment, or is a direct effect of the COVID-19 infection. Differentiating heart failure, which happens in a patient that comes in with any kind of reason, for example, they forgot to take the medication, if they had been having any dietary issues, it's very hard to differentiate it from ARDS or acute respiratory distress syndrome. And frequently it's associated with a hemodynamic insult, and it becomes very challenging. So we just go by what the chest X-ray show, what the CT scan show, and we go accordingly. Cardiac arrhythmias with COVID-19 has been reported, and it does increase the stays in ICU. Usually you see mostly ventricular arrhythmias, PVCs, PACs. 1 case of atrial fibrillation was there, but it doesn't seem like atrial fibrillation is as common as ventricular arrhythmias. There is some critical consideration that is being given all over the place for the use of hydroxychloroquine as well as Zithromax in patients with COVID-19. I'm not sure where the patients are getting the hydroxychloroquine. Some are saying that they're getting it through Amazon, and some are being able to get the Zithromax from their private physician on the outside. But the caution has been there by American College of Cardiology, American Heart Association, as well as by the Rhythm Society, because it is a definite cause of torsade. EKG and QT interval monitoring is very important in these patients with guidance for drug withdrawal. We have to correct their electrolytes, make sure that they're not hypokalemic, not hypomagnesiemic. Hypomagnesemia has to be corrected, otherwise the potassium doesn't stay good in these patients. We have to avoid other drugs that can prolong QT interval when feasible, and we are looking at potential adverse events of medications currently being repurposed for COVID-19, such as chloroquine and lopinavir, and as well ritonavir. In the previous merit conferences, a lot of people have talked about hydroxychloroquine, if it can be used for prophylaxis. There are no studies to prove one way or the other. One person, Bill O'Neill, is trying to do a study. He's put up the proposal at this time. He's an interventional cardiologist at Henry Ford Hospital, and he plans to study 3,000 healthcare workers and first responders who volunteer to participate. He's trying to look at, will hydroxychloroquine impede or prevent COVID-19? And as you know, these kinds of trials take almost like 3 years to complete, and it will take a year or so before the results will ever get published. Cardiac biomarkers adjusting in COVID-19 is also important. We do see some troponin elevation, but it is advised not to measure troponin unless there is a diagnosis of acute myocardial infarction is being considered on clinical grounds. BNP elevation is noted in patients with severe respiratory failure, in the absence of elevated filling pressures and also with clinical heart failure, so that it becomes very difficult to differentiate between the two if you see a BNP elevation. So if you see a BNP elevation, it's a poor prognostic marker, but we do not recommend testing it routinely in a patient that comes in with heart failure. You may do it once when they're admitted, but after that, we do not really recommend doing it on a routine basis to see the prognosis of the patient. Follow-up tests, echo and cardiac catheterization are done only in those where it may make a difference. Antithrombotic therapy is not given. There's no data for antiplatelet or anticoagulant for acute myocardial injury except for type 1 myocardial infarction. We use selected tests only as needed and is considered as emergent or life-saving. For example, somebody coming in with suggestion of acute aortic syndrome or aortic dissection, or somebody coming with suspected P. They go for CT angiography. And if only P is suspected, sometimes we don't do the CT angiogram, but take the patient for D-dimer and lower extremity ultrasound, because every time a CT lab is used, they have to make sure that they are decontaminated before the next patient can come in, and that delays the treatment of the patient that follows after them. For acute ACLs, we are only using EKG and standard biomarkers for cardiac injury, and for acute heart failure, we are following up by chest X-ray and point-of-care ultrasound. In our hospital, we do have a discharge instruction template pre-built into the computer. And once the patient comes into the hospital, all of them are given instruction according to what the status of the COVID-19 is. When this checkbox is selected, the template opens up, and then it allows us to choose if the patient's test results are pending, negative, or positive. You can choose only one of the three. And based on what you choose, those instructions are printed for the patient to take home. WHO has put in the guidance to make sure that COVID-19 is prevented as much as we can do it by doing simple things around the house, disinfecting surfaces around home and work. And we are expected to disinfect our workstation upon arrival to the hospital. And then at the same time, we do it again when we leave the hospital. We wash our hands as recommended, and sneeze and cough are covered. And we always make sure that we have our mouth covered when we leave our room if we have that exam room alone to ourselves. Lockdown and social distancing has really helped us. Strategies to prevent COVID-19 infection that is being practiced in our hospital is rapidly changing. Our interaction with patients and colleagues have changed. We have social distancing, we use Skype, we use video conferencing and social media. The problem is that we're affecting the house staff, and they're not getting that much up in the hands-on experience that we would like them to see, but we have to protect them as well. We as elderly patients with multiple medical problems, 6 weeks ago, the concern was about COVID-19, which was considered to be abstract. We were thinking about it. We are talked to them about personal protective measures. But in the last 3 weeks, the threats of infection and disability and deaths are getting real and humbling. Questionnaires are being followed, patients are being contacted by phone or by video, and we are being told to remind ourselves to listen, really listen to patients and see what they're saying, because we're not really seeing them face to face. Some of them may be there on video chat, but most of them don't really have FaceTime to go to video chat and are just using the regular phone to answer, or using their cell phone to answer our questions. And we just have to decide based on the respiration, how they're talking, if they're breaking down. That's when we decide if they need to come to the hospital for face-to-face, or do they need to be given the medication as needed. We have gone into remote monitoring as far as possible. In the heart failure clinic, no patient ever leaves without a blood pressure cuff and a scale. And now it is being utilized more by other places. I mean, by other clinics, primary care clinics and pulmonary clinic, all of them are now using the same telehealth as we had been doing, and education is being promoted. These blood pressure monitors and weight scales automatically transfers the patient's blood pressure and the heart rate and weight onto our system, and the nurse reviews them every single day. Every nurse, if few patients are assigned to a nurse, and they look at it, and if they see something that's going up or down, which is not appropriate, then they call the patient, and then they decide if it needs to be escalated to have a physician evaluation over the phone. We do have support health group, nursing, support staff, and physician to answer questions. We renew the medications online. At first, I was very skeptical. How can I review it without seeing a patient? But now it has become the norm. We review the labs as necessary. We're telling the patient to get the lab results or to get their lab test done at a clinic which is closer to their home and have them inputted into the medical record system. They either send it to us or they send it to their secure messaging system, whichever they like. And we use that lab results in order to decide if the medication can be renewed. Cardiac devices, they're being interrogated by remote monitoring rather than in-person visit. Most pacemakers, ICD device, are monitored for arrhythmias, elective replacement indicators, activity levels, fluid status, as well as cardiomems with or without phone support. Most routine CID evaluation, office evaluation are now being converted to a remote monitoring. Beforehand, we had remote monitoring every 3 months, and we would do the in-office evaluation every 6 months. Now they're moving the in-hospital or in-office evaluation to almost like once a year now. Anytime a patient needs a virtual visit, we have the remote monitoring check done prior to the virtual visit so that the time is not taken looking at the data. The data is there for you before the patient tries to put in any additional data. We are using telehealth for phone consultation, test results, etc., and we do pre-operative evaluation for patients for CID implantation, generator replacement, etc. Post-op, we're doing the wound check by using video or photo being sent by the patient through a secure portal. We are hoping these will help. We are not canceling any appointments for outpatient clinic, but converting them to phone or video appointments. It is a stopgap measure, but we feel like it may be coming in to become more of a norm because patients seem to be liking it. Sometimes it means that the next face-to-face appointment may be sooner, but only time will tell. Most of the cardiology consults are being done by e-consult, by chart review, phone, or video chat. Some of them are being delayed. All of the testing that is done in the lab has been postponed to as much as it can safely be done. We are not doing any TEs or stress echoes. An occasional TE is being done for an inpatient that has really a good indication to get it done. If somebody is thinking about aortic dissection, we are sending them out for CT scan because there is no oral intubation required for that. And if they're thinking about endocarditis and a suspicion of an abscess is there, for example, the QRS complexes are getting wider, patients are developing heart block, then only we are doing a TE, otherwise not. We do have a research plan in place. Since this is a teaching hospital, we have to teach the resident and the fellows as well. So we have a trigger for 10 patients, more than that on the CCU, and we also have a consult service. We add an NP. If it's more than 15, we add another cardiologist to the inpatient service. And if it's 32 patients in the IC service, then another cardiologist leads an extra team for MIC and COVID care patient. We're keeping the volume as low as possible. And so far, we have been successful not to use any of the triggers so far. These are the phone billing services that I decided to put in for some people that had questioned it last time. And these are the HIPAA compliant video communication products that are available. At the VA, we have the video chat that is exclusively for the VA. At the university, they're using different brands. So this is a list of the video compliant, HIPAA compliant products that are present. Our outpatient phone and video chat flow has changed. We have the medical assistant call the patient in advance, gets a verbal consent for the telehealth visit and documents that, ensures a setup for the televisit, make sure the patient has an app, has a clinical reminder via the text. They confirm the location and associated caretaker, make sure the patient is at home, and review the past medical history, medicine, allergies, and enter any other vital signs that are obtained at home. It is very important that to document in the template the city that we are calling from and the state where the patient is located. At the VA, it doesn't matter to us because we are federal, but at the university, they're expecting the resident to make sure they write down where the patient is located because it changes the liability issues over time. ACC has given some guidelines about that. They expect to check with the malpractice insurer to allow us for remote visit in this capacity. There is a local alert. Those practicing on the edge of a state line need licensing in multiple states. Do telehealth encounter service is taking place at the physical location of the patient, not the provider. Documentation has to be similar as it is for any visit, except we have to add a statement documentation saying that the service was provided through telehealth. And a lot of states are trying to help us out, making sure that the commercial insurance allows and reimburses televisit at the same rate as an in-office visit. So the future after corona pandemic is something that we need to look for. Is it going to be remote work? Will there be more automation, or will there be telemedicine? Will that be the norm? Will there be more digital services? There are some self-service ER that is being promoted, where the patient goes in, puts in their vital signs, puts in their a question, and based on what the question that they put in, with their lab results, their receipt comes out asking them to get certain kind of lab tests or EKG to be done or chest X-ray to be done, and the location where they need to go and get it done. And when they come back to that particular location back again, they are told what needs to be done next. Either a nurse comes and visits them, or a prescription for a medication that needs to be given. The question is asked on the monitor, and the patient decides which way to go. There are some also questions about doing remote capable PCI, but that's not part of this discussion. Telemedicine and med tech innovation is going to be the norm, but the question is HIPAA regulation. Higher education has gone online. We're limiting hands-on experience for the residents and the medical students. And we hope that there will be more communication across states and nation. This picture was sent to me by one of my colleagues only this morning, and I hope we can use it to encourage our colleagues back in Pakistan, since Ramadan is coming and there is a big push to do Taraweehs in the masjid, and if we can avoid that, that will be great. I appreciate your interest and thank you for your attention.
Thank you so much, Dr. Moteen, for a very nice review. Really appreciate it. So I'm just gonna ask all the panelists to quickly introduce, and we'll get right to the questions afterwards. I'll start. I'm the interventional pulmonologist and intensivist at University of Oklahoma and director of IP services. And I'll unmute all the panelists. Dr. Shahid, if you wanna introduce yourself. So I have to mute again, I guess.
Okay.
Yeah, okay.
No, I got it. Assalamualaikum. Shahid Rafiq. I'm actually a vascular neurologist and sleep specialist in Frederick, Maryland. I am a chair of APPNA MERIT, and that's how I'm involved in this great program, which actually is our stars are ID specialists, intensivists, and all those internists and clinicians who are directly dealing with COVID patients. So,
Dr. Rafi, sorry, go ahead.
Yeah, I'm Dr. Zafar Nafi. I'm a psychiatrist and psychoanalyst at Harvard Medical School at McLean Hospital. I'm one of the panelists today. My specialty is addiction psychiatry and eating disorders patients.
Very good. Dr. Kabani? Somehow she's not getting unmuted. Dr. Kabani?
This is Dr. Kabani. Yes, I'm a pulmonary critical care physician in Houston, and I do tele-intensive care medicine as well.
Thank you.
Thank you.
Professor Shamsa Humayun?
Assalamualaikum. Can you hear me?
Didi, we can hear you. Please introduce yourself.
I'm a professor and head of obstetrics and gynecology at APPNA Medical University, Sir Ganga Ram Hospital, Lahore.
Okay, very nice. Thank you for joining us. Dr. Muhammad Salim, please introduce yourself.
Consultant in Kotli, Azad, Jammu and Kashmir. Thank you.
Thank you so much for joining. Dr. Bushra Ali, please introduce yourself.
Assalamualaikum. Hello.
जी, वालेकुम अस्सलाम. आपकी आवाज आ रही है.
जी. People know me as Bushra Jamil, so some people may be wondering who's Bushra Ali. Anyways, I'm Professor of Internal Medicine and Infectious Diseases at the Aga Khan University, and I'm also the president of Medical Microbiology and Infectious Diseases Society of Pakistan.
Thank you, and very nice to have you here. Dr. Kaleem, please introduce yourself.
Kaleem Ahmed, I'm a pulmonary critical care and sleep medicine in Maryland.
Very nice. Okay, I think I have gone through the whole panelist list. Okay, so I'm gonna go a couple of questions I answered. I think I don't see any further questions, and then in the chat I also don't see any question as yet. So I'm gonna take some of the questions until participants raise hands or ask questions. There were some questions on the WhatsApp group. One thing I want to say is there are a lot of hematological and questions regarding red onc. So I'm trying to connect with some of the oncologists who can come and join in one of the meetings to answer those. But there was a question by Shayan Khan who said that how can cured COVID positive patients plasma would be a help in the current situation? So I'll just throw in a quick answer and then the panelists can comment on. There have been two main studies, one with 10 patients and one with 5 patients out of Wuhan, and they had positive response in terms of once they received the convalescent plasma. Some of the studies are being done here in US at this point. Our own center has given convalescent plasma. It has a decent response in terms of improvement. The study that was published in the end of March, it did have 4 out of 5 patients did get activated as well. So there is some degree of viral neutralizing antibodies that at this point we do believe that might help. But again, research is on the way, and I would ask the rest of the panelists who want to answer further on this question, especially if Dr. Bushra Ali, you have some, comment on that, that would be helpful as well.
You want me to go first?
Yeah, please go ahead.
Okay, so convalescent plasma treatment has been approved by our DRAP nationally, and I think NIBD has registered with FDA to start, and we are also preparing to initiate convalescent plasma treatment at the Aga Khan University. The thing is, nobody's sure about the degree of benefit people may gain out of plasma treatment, but our experience is evolving and we are seeing more and more sick patients. So when you do not have any definitive treatment available, you want to try all the suggested treatment modalities which may benefit the patient. So yes, NIBD is starting treatment and AKU has made all the preparations to initiate therapy. We do not have a patient yet who has received convalescent plasma. So once we gain experience, I will report back.
So in your institution, the way we are doing it with the high inflammatory markers, we have been using tocilizumab. And then once the convalescent, we get into the trial, we have a side parallel track. So the patient that have so far received are those that have not done well despite other therapies, including tocilizumab or the anti-inflammatory or anti-IL-6. But now we have a parallel track. So how are you going to decide which patients are you going to use the steroid / tocilizumab, or you're going to go directly to convalescent if it's available?
Tocilizumab, we've had a very good experience. So we've prevented patients from going on to ventilators. So any acutely ill patient who's deteriorating, we give tocilizumab and get very good results. Maybe convalescent plasma should be used in a similar manner and early on rather than waiting for patient to deteriorate, and because those are the kinds of patients who are currently being considered for convalescent plasma. Although personally, I believe when it's too late, convalescent plasma may or may not help. So treatment should be initiated early on if you want to get any benefit out of it.
Agreed. Dr. Kaleem or Dr. Zafar, you have anything to add? On the convalescent plasma question?
Yeah, so as we know that there are multiple studies going on, the studies from the China was kind of a little bit hodgepodge because they have thrown the kitchen sink. Everything was given to the patient, so we don't know the positive result of whether it is related to the multiple angles of the treatment or it is just primarily because of the convalescent plasma. The second thing is that currently we don't have the accurate measurement of either the point of care, the IgG and IgM testing, ELISA testing is also kind of in between. So in the presence of these kind of limitation, the policies which is beyond the RCT trial related therapy, how you guys are implementing the convalescent plasma? Are you checking certain levels of the titers, presence of IgM, IgG? What exactly is the process?
Go ahead, Dr. Bushra, and then I'll answer you. Go ahead, please. Do you have,
So we do not have very good quality ELISA tests available at the moment. But in the current situation, actually, CDC allows the donor plasma to be stored and checked later for antibody titers. So anybody who's had evidence of infection more than a month ago is being presumed to have adequate levels of antibodies and can be considered a donor. So that's the presumption on which we will be working on. We have a kit, which is an ICT-based kit, not the best of technologies, but that we can use for initial screening and save the donor plasma for testing later on when the robust kits are available.
Good question, Dr. Karim. And we at our university, we are part of the trial. So that's how we're using. Anything else? Anybody else wants to contribute? And I mean, of course, that's based on inflammatory markers, and it's a lot of work. It's a multi-center trial. Okay. So any other questions? So I'm going to go to the second question, which is in WhatsApp again. And this is by Dr. Azharul Hassan Qureshi. So he asks, I read an article which indicated that remdesivir might be helpful in serious patients. Anyone knows if it's available in Pakistan, and if not, how long before it can become available, and how the people actually working in the US are seeing the results in their setups with remdesivir use. Okay. So again, I can open up first before I answer. Dr. Kaleem or Dr. Bushra, do you have any comment about remdesivir in your experience? And then we can talk about Pakistan specific.
In our institution, we are unable to get it because they are not allowing us, because the number of patient population is not as much as in other centers. So they have not allowed us to be part of the process. Our understanding is that beyond the use in a specific trial, centers are not using it. This is what I know.
Dr. Bushra?
Remdesivir is not available at the moment, and the process of getting the drug as part of trial is very lengthy and cumbersome. So what we have done is applied to the company and to DRAP to provide it to us on compassionate use grounds. So we have requested that some of these medications which are not registered with DRAP and are not available in the country be procured. And centers which are seeing COVID patients should be allowed to use them on compassionate grounds. So we've sent in our application and we're waiting for a response.
I see. So Dr. Zafar Naqvi, do you have anything to add?
No, thank you. I do not have anything to add.
Okay.
If there's a question, I will be happy to answer. Yeah.
Professor Shams Humayuddin, I believe. Full name is not there.
Shamsa.
Do you have? Yeah, Professor Shamsa. Professor Shamsa, do you have anything to add?
No, not really.
Not in your institution. So in Pakistan, you still have compassionate grounds to ask for remdesivir. That's interesting to know if they are considering that, because it was not. It was there initially in US, but not anymore. Okay. So regarding remdesivir, again, the trial that came out about 50-ish patients, that's done by the company itself, and again, it has, I believe, 17-18% mortality in a lot of intubated patients. A lot of flaws in that trial as well. That again, multiple other trials are going on. I think in our institution, a couple of patients were tried. I was not part of those patients, but from my colleagues that I. Sorry. I missed that. So there was not any significant difference. One of the patients I know that I later on came on the case, I had to give tocilizumab as well, and that's the same patient. After 23 days, he got the convalescent plasma. So I mean, we don't have a lot of experience with remdesivir ourselves. 2 patients, I believe, received it. But again, I think that is worth considering, especially with the one of the studies that came out with 50 patients or so. May or may not work, but again, ultimately the randomized trial will be better. Anybody has any other comments before I go? Okay, I think Kaleem has. Kaleem bhai, please go ahead.
Well, yes, I would like to ask Dr. Moteen about the cardiomyopathy related her experience. As we have seen the data from New York, that about 35% of the very critically ill patient was reported to have cardiomyopathy, and how you're dealing with that in your institution, and could you please, educate us about that?
In our institution, we're just treating them as a regular heart failure patient. We're giving them the heart failure medication as far as they can tolerate. Most of them, the blood pressure is low, so you're kind of limited as what are the medication that you can give them. Yes, they do develop both left ventricular failure, and some also develop right ventricular failure. And their volume status seems to be much lower than what we would anticipate in a patient with heart failure. So that makes it a little difficult, and let alone their medication, they tend to go on pressors to help them keep alive at that time. But once they get out of the ICU, that's when we start manipulating their medications a little bit more, giving them a little bit of ACE inhibitor or low dose beta blocker if they can tolerate. And they seem to do okay with it.
Okay, thank you.
Okay. Dr. Salim, please go ahead.
Yeah. My question is from Dr. Maryam Moteen. Is there any role of corticosteroids in COVID-19 myocarditis?
That has been questioned quite a bit. I have not used it myself. One of my colleagues has tried it, and they found that it looked a little bit useful. The white count started getting better instead of getting worse. So I'm not sure, it's difficult to say. In the literature, they have described that it has been found useful in certain cases. I'm sure Fawad may have seen some cases as an intensivist, and he may know better.
Right. So regarding myocarditis specifically, we have not used, and in our institution, we have not used steroids, but there has been controversy about steroids in general, as we all know. WHO, CDC has recommended against, but SCCM has recommended for severe ARDS in place of like whether you use tocilizumab, IL-6 inhibitor versus steroids. Some centers are using it. One of the centers is Memorial Sloan Kettering Cancer Center, which is a big center with a lot of cancer patients as well, and they have decent outcomes. Their paper is not published. So in China, we know they tried it. So they had some, questionable results. Most of the studies came out of China, gave us some idea, but most of them were not randomized, of course, so we cannot completely decide. So that's where we stand. I do believe if you do not have anti-IL-6 and you have inflammatory markers very high, ferritin, CRP, and patient is going into cytokine storm, I think consideration for that indication should be given for steroids at that time, not in the early phase. Regarding myocarditis, I don't have any experience, or neither did I try. Maybe Kaleem or somebody else can pitch in there.
No, I have not used that in a specific myocarditis thing. That's the reason I was trying to figure out. Yes, in a very septic patient, one patient, we tried that thing when the blood pressure was going down, and after adding 2 vasopressor, we were not able to maintain. But that is a one patient only, so not in a specific myocarditis.
I have another question on the WhatsApp again from Dr. Mohammed Faisal, and that is somewhat linked to Dr. Moteen. Again, I will go that direction. He's been suggesting that in India, many of the healthcare physicians have been asked to do chloroquine or hydroxychloroquine for prophylaxis. A single dose of 200 milligrams of hydroxychloroquine every 3 weeks. India is now recommending a 7-day course of prophylaxis for healthcare workers or other closely exposed to COVID-19 patients. So he's asking about post-exposure prophylaxis recommendation. Again, this is not a recommendation from CDC, from any of the different societies from US. And again, for 2 reasons. Number one, it has cardiac side effects. Number 2, the data is not clear. French studies without any randomization did show that it decreases the viral load. We know the mechanism, it can inhibit the ribosome associated entry into the cell. But there is no, as of now, we don't know if those patients will benefit. And then there is another trial that came up early April that showed that those patients who received, I think it was a 40-50 patient trial, they actually did not show any benefit. In fact, most of them got intubated despite receiving that. Most hospitals have that in protocol, even in our institution. But we are not at this point sure if it really helps in improving symptoms. It can decrease the viral load as per the studies from France. But QT-wise, I don't know, and I would let Dr. Moteen, Dr. Bushra, and Dr. Kaleem to pitch in. I don't think so. It should be done as a prophylaxis.
So far, none of the studies have yet shown that it is going to be of any use. There have been an occasional patient in which they may have found it to be useful, but then the side effects of these drugs with QT prolongation causing torsade, that becomes a major issue. That's why it's not recommended, but people have it in the protocol. They want to try it, and everybody's hesitant to use it. So this guy that I mentioned, Bill O'Neill, who is an interventional cardiologist, I think it was in Cleveland before, but now he joined Henry Ford, and he's planning to do a study, and we are hoping it will give us some answers, but it'll take at least a few years before we come to know if it's going to be of any use or not.
Right. Dr. Bushra, do you have any comment?
We are using hydroxychloroquine fairly liberally, keeping an eye on the QT interval and so on. So no dramatic effects. No, not for prophylaxis. So we haven't seen any dramatic effects or major side effects of hydroxychloroquine. So very limited experience yet.
And I think Dr. Kaleem, anything from your end? Dr. Kabah, anything to add from your end?
No, same as everybody is mentioning. So no, nothing new.
Dr. Kabani, anything from your?
No, we're not using it for prophylaxis, but I see it in a lot of the hospital protocols. And the main thing is to monitor the QT and also look at the drugs the patient is previously on when you're adding on hydroxychloroquine, which can also be a problem with adding it without consideration for that.
Yeah, I think we are all actually clear. At least we should not use it for post-exposure prophylaxis. Yeah. Professor Shamsa, do you have anything to add?
I just wanted to ask about the prophylactic role of hydroxychloroquine because in our hospital, because my hospital is declared as COVID specific hospital for the pregnant ladies. तो मेरी अपने यूनिट के मेरा ख्याल है कि 50 से 60 लोग हाइड्रोक्सीक्लोरोक्विन प्रोफिलैक्सिस ले चुके हैं. It is very popular here. वो एक गोली 200 mg की खाते हैं और फिर after 3 weeks they have another tablet. So I don't know. It's just your conviction. No scientific reason. तो मैंने भी ये पूछना था कि बाकी दुनिया क्या कर रही है.
नहीं, I think it happened even in US के pharmacies before it all happened. A lot of people got it. Lekin it's not recommended at this point. The only time we in our protocol at the university where I work is once they have risk factors and they are COVID positive, we are giving them as a first step as long as their QT is normal and not coinciding with other QT prolonged medications. So I think the effect is yet to be seen, but not in my knowledge any society has recommended for prophylaxis at this point.
I think one point that we all need to remember is when we are taking it for prophylaxis with no benefit, there are many patients that are chronically on this medication that are not being able to get it because of the dire shortage.
The rheumatological disease and all that. Yeah. Okay. So there have been some oncological questions, as I mentioned, and there are a lot of those questions. I can go over with a couple of those, unless there is another. I don't see another question from the group of attendees here. There are no raised hands. So let me. Okay, Dr. Muhammad Salim. Dr. Salim, you have another question or comment?
Yeah, I have another question, and the question is that patients in COVID-19 with focal myocarditis, they may present with chest pain, and there is also increased troponin levels, and there are STT changes. How we differentiate from coronary artery disease?
These patients, we just follow their patient clinically. We don't really give them any kind of special treatment except continuing with their aspirin beta blocker and the statin if they can tolerate it. Otherwise, we don't really take them to the cath lab. We don't do any stress tests. We just follow with an echocardiogram looking for regional wall motion abnormality, any changes in the LV function, if we can find, and treat them symptomatically without taking them for any kind of major procedures.
Okay, thank you.
Dr. Nigat, please go ahead. Dr. Nigat has a question.
Always, it's such a useful seminar which APPNA has put up. I'm linking lots of people to it. Being a rheumatologist, when we know that it has no role in prevention, why doesn't this thing get enforced? Because we are facing acute shortage of hydroxychloroquine for our lupus patients, and obviously with APLS and all that stuff. So why are we still, why are still hospitals all over the world still using it? Why can't we strongly come up with a statement that this is one question? And the second question is that when patients who get better, when they leave the hospital, maybe 3 days, 4 days, and you want to make sure that they are, isolating themselves at home. So how do you monitor them? And do you just give them a guideline? Do they, is a nurse practitioner following them that they are self-isolating and they are being taken care of? And I think it's time that we also discuss a home care plan for people with mild or people who are discharged, and how do we go about it? Because this is going to be coming very soon.
Meaning those patients that are discharged after being treated?
Yes.
With COVID positive?
Yes.
They were like mild to moderate, or they were in ICU, they got discharged. How are they being followed? Okay.
Yes.
So anyone in the panelists wants to take the question?
I would like to respond to this concern about HCQ becoming out of stock. So MMIDSP, which is Medical Microbiology and Infectious Diseases Society of Pakistan, we did take out a press release weeks ago warning everyone that there is no specific known or proven role of hydroxychloroquine and azithromycin. It was on both of these together. And chloroquine, hydroxychloroquine in the management of COVID, management or prophylaxis, and people should not be self-prescribing it or hoarding it in the mistaken belief that it will protect them from COVID infection. Perhaps we should take out a press release again, just to remind everyone that even up till now, there is no sound evidence for the use of HCQ or chloroquine for prophylaxis or even treatment of COVID. So we will do that. And regarding the post-discharge management or guidance to people, I think individual institutions are doing it on their own. There is no guideline from the government, but even the government hospitals which are running COVID services, and there are infectious diseases consultants there, they have established some kind of program for people who go home so that they get regular phone calls, and where they are asked about their symptoms and they are counseled and they are reminded that they have to stay in isolation, and they are reminded about the timings or when they have to get their samples done again. So because it is important and that is being followed.
Dr. Moteen, you have something to add.
It's we have pre-printed instructions that are given to the patient upon discharge, and the nurse follows up with them every single day on every working day.
Okay.
Thank you so much. Thank you so much. Because our patients who are immunocompromised, there's a guideline that if they are on biologics and they have comorbidities, they have to self-isolate. So we did make a health, home care plan, and I think I'll mail it to a few of you to review so that it's available on their WhatsApp phone, and they can be monitored by a phone call by a volunteer nurse practitioner or a fellow, so we'll like to share with a few of you to give your comments. Thank you so much.
No problem. So is this, was it your comment or it was still a question? I kind of missed that, Dr. Naheed.
No, it was a comment.
Oh, okay. Thank you. And we do agree. I think it's a good idea. And I just wanted to add on the chloroquine and hydroxychloroquine aspect. We totally agree. And there are trials going on. The French studies were not very convincing. Prophylaxis, that's the same issue in US. Like people with lupus, they are not being able to get it. And it's been taken off the shelves for the most part. So it's until we have more data come in, unfortunately, we are stuck in this. Even treatment-wise, I'm not sure how much effective it is, other than reducing viral load. Maybe it is, we'll know. But prophylaxis is just insane the way people are doing it. Okay, I think it is. Let me see if there is any more raised hands. I don't see, and I didn't see any Q&A. So I think we should actually call it and finish tonight's session, so we are not too much out of time. And as I said, there have been some other questions that are on the WhatsApp, and we'll try to answer them with a particular specialist, which will be mostly oncologic and in red onc side. If not, then I'll try to answer in my own presentation in a couple of days or so. Let me see one more chat here. Okay, so thank you to all attendees and participants, as well as panel members. And if Dr. Shahid is still there, I will ask him to close it. Dr. Shahid, do you have any closing comments?
Yes, so I was going to write, and so I can basically tell the attendees and panelists that we have run this nightly here in US. It was nightly and morning seminar in Pakistan for now, I think 20 days. And so 4 more days until Thursday. Thursday will be our last nightly or morning Pakistan morning seminar. During Ramadan, we had taken polls from Pakistani attendees as well as US attendees, and overwhelmingly people said not daily, but just on weekend. So respecting that, and in the timing that we got more responses, that if it is after Sehri in Pakistan, which could be like around 7 or 8 a.m. Eastern Standard Time. So in Central, it will be 6, or, in Mountain or Pacific time would be even earlier. So we can figure it out as we go, but to test those two coming Saturday and Sunday, we will do 8 a.m. Pakistan Standard Time, which will be, Eastern Standard Time, which will be Pakistan Standard Time will be 5 p.m. So we hope that, because I think the iftar in Pakistan will be 7. So if they will attend 5 to 6, and then of course they can arrange for their iftar and all that. So I think for now that time seems okay, but we can adjust it as we go. But instead of every night, it will be only on Saturday and Sunday. So we had speakers for Saturday, Sunday. We have to request them that their talk will be in the morning here in Eastern Standard Time, which will be evening in Pakistan. So we will announce that in other media that we have, but we'll continue until Thursday every night. So we'll see you tomorrow, same time, 8 a.m. Pakistan time and 11 p.m. Eastern Standard Time. So thank you very much for everybody.
Thank you.
Thank you.